Welcome. This is Brian Wood, Medical Director for the Mountain West AETC Project Echo Telehealth Program. Each of our weekly sessions starts with a short talk focused on issues relevant to HIV clinical medicine. The following talk was recorded live here at University of Washington. We will now take you to this week's talk.
This may be a review for many of you, but some questions have come up for me recently in clinic having to do with choosing initial ART and managing first episode of virologic failure. So I'm going to present this. Again, some of it may be review, but I'll also pose some questions for discussion and for thought, and may even ask for a couple of thoughts from our panel here. So 2 goals: review current options for initial ART, the considerations for choosing between the options, what's used most commonly, why we may or may not choose those, and then recommendations for lab monitoring after starting ART and management of first virologic failure. So this hasn't changed recently, but I just want to do a quick review, and these are from the Department of Health and Human Service guidelines of the recommendations for initial regimens for quote-unquote most people with HIV. So these are the regimens we'll be reaching for in most circumstances. We've talked before in this community. I think most of us are reaching for bictegravir with TAF and emtricitabine first. That's generally been, I would say, my most frequent initial ART prescription recently, with exceptions being if it's not covered by insurance, then I'd say I'm most frequently reaching for dolutegravir plus TAF and emtricitabine, which is Descovy. Those are probably my most 2 frequent initial start regimens recently, and the question that came up in clinic the other day is, well, when would you not reach for those? And that got me thinking a little bit, and so I'll put that out to you to think about as well. A couple of things that came up for me: we've talked about the concerns about dolutegravir potentially raising risk of neural tube defects. So for someone of childbearing potential who's not using effective contraception, that might be a situation where you might not reach for dolutegravir, and we really don't know the best alternative option in that setting. Hopefully we will get an update on data on that topic as soon as next week from the IAS conference. There was a paper from the most recent edition of the AIDS journal just last week looking at dolutegravir in zebrafish, and it did affect the folate receptor and reduce folate levels, and that was overcome by folate supplementation. So there may actually be a mechanism for dolutegravir reducing folate levels or folate activity and leading to neural tube defects. But again, we need more data on that. Other scenarios I was trying to think of, when might I avoid those options? If someone had significant insomnia or headache at baseline, I might have a conversation and consider whether dolutegravir was appropriate. That does seem to be a little better with bictegravir. Other scenarios, if somebody has TB co-infections, getting rifampin, I certainly would avoid bictegravir because we can't double the dose, and for the time being would avoid TAF. So then I might be reaching for alternative options. But let's put that to you to consider. What is your most frequent ARV prescription for new starts these days, and why might you choose or not choose those which we're using most commonly? And we'll come back to that at the end, and we'll ask colleagues here as well anything to that discussion. For the quote-unquote second line or alternative or recommended initial regimens in certain clinical situations, I'll just do a quick review here. This isn't an exhaustive list, but just a reminder that the boosted elbaptegravir regimens really have fallen from first line because of tolerability and drug-drug interactions from the cobicistat and lower barrier to resistance as compared to bictegravir and dolutegravir. I can't think of a time recently I've started somebody on a boosted PI as an initial regimen, so I think those are being used, especially darunavir, much more for salvage these days than for initial regimens. And then just wanted to do the reminder that we really aren't starting individuals on efavirenz-based regimens as first-line therapy anymore, except in rare circumstances. TB co-infection with rifampin, that might be a reasonable 1 pill a day, but that's about the only scenario I can think of where we'd be using the efavirenz-based regimen. I think the rilpivirine options, especially the one combined with TAF FTC, are reasonable for individuals in whom you suspect will have great adherence, not on a PPI, relatively high CD4 count, low viral load. But now that we have the integrase inhibitor-based options, I'm not reaching for those as much anymore. And then the doravirine combo with TDF and lamivudine, I have not written a prescription for initial ART yet. I actually don't think I've written a prescription for this combo pill yet, although I have used doravirine in a handful of cases for salvage. So that is mostly review. And then the other thing I wanted to highlight is what the Department of Health and Human Service guidelines say we could consider in the setting of an individual who ideally shouldn't get TAF, TDF, or abacavir. So let's say somebody has a creatinine clearance below 30, so we ideally don't want to use TAF or TDF, and maybe they have cardiovascular disease or a positive HLA-B5701, so we need to avoid abacavir. So these are the options that the Department of Health and Human Services currently list. Dolutegravir lamivudine, so remember that combo tablet has been approved. Boosted darunavir plus BID raltegravir, which has been studied with these caveats. It did not do as well as comparators with low CD4 counts or high viral loads. And then there was a study out of Europe of boosted darunavir with lamivudine for initial therapy, which did seem in most individuals to be as effective as boosted darunavir plus TDF-FTC. So those are the options listed in the guidelines. I was trying to think back, and I haven't written a prescription for any of these for initial starts. Now in the era of TAF and all the options we have, I have not really been reaching for these, but I'd be curious if anybody has used these in rare circumstances where you're trying to avoid the other NRTIs. But that's what the guidelines list as options if you need to avoid TAF, TDF, and abacavir. So some of the considerations when choosing initial ART, so certainly CD4 count and viral load. For example, if you're considering rilpivirine, you want to make sure to review those. If you're starting ART before the genotype results are available, which is very reasonable to do, we've talked here about starting earlier and earlier, even the first clinic visit, even the same day or first week of establishing care in your clinic. And Dr. Danaretti is going to talk more about the logistics of that. That's scheduled for September. So if you're starting before the genotype results are available, the key per the guidelines is avoiding NNRTIs. The integrase inhibitor options are very reasonable given the low rates of transmitted integrase resistance, and I would add to that, especially if you're using dolutegravir or bictegravir, because of the robust barrier. Certainly, I think this audience knows a B571 is always needed before considering abacavir. And then other considerations, pill count and size, tolerability, food requirements, comorbidities, for example, renal function, liver disease, osteoporosis, mental health, cardiac risk, hyperlipidemia, and others. I think pregnancy or desire for pregnancy or use of contraception is an important one to remember, as are co-infections, like hepatitis B, in which you'd always want to make sure somebody was on a tenofovir-based product plus another NRTI and not use, for example, abacavir lamivudine as the backbone. Hep C, and thinking about Hep C co-infection and drug-drug interactions, and then I mentioned TB drug interactions, and then of course insurance coverage. My experience recently for new starts is often I'm turning to my pharmacy colleagues, asking them to do a test claim for bictegravir TAF FTC. If it is likely to be approved, that's what I'm going with, and if not, then I'm considering the other options. But again, I'll put the question out to all of you. When are you considering those options versus others, and other scenarios in which you're reaching for non-dolutegravir or non-bictegravir options for first-line therapy? Monitoring after ART, I just want to highlight a couple of things. Many of you are aware the guidelines recommend rechecking the viral load or HIV RNA at about 4 weeks after ART initiation, and now with modern therapy with integrase inhibitor-based options, that viral load really plummets in that first month and we see dramatic drops. Then every 4 to 8 weeks until the viral load is suppressed. The guidelines note that suppressed they consider less than 200. I think in clinical practice we're really monitoring every 4 weeks until it's below the limit of detection of the assay. So for us, that's below 50. Wherever you work, that may be below 20 or below 40. Then every 3 to 6 months, and then the guidelines say once the viral is consistently suppressed with stable immunologic status for at least 2 years, extend to every 6 months. And that's usually my minimum. I usually don't extend out longer than that, even though some of my patients really say, why can't I just check in every year? Or why do I have to keep coming? Usually my minimum requirement is every 6 months to check in on adherence, check safety labs, and review primary care issues. And then we've also reviewed here CD4 count checks. We've really reduced the frequency of monitoring CD4 count checks. And I think a key point here is that viral load is really the most crucial for monitoring whether ART is working, whether a person's taking the ART, whether there's any sign of virologic failure, and we'll come back to that in a moment. CD4 count helps to know which opportunistic infections someone's at risk for, whether they need prophylaxis. But really, once somebody's on ART with a robust CD4 count, there's really little clinical benefit to frequent monitoring. And what the guidelines now say is after 2 years on ART with suppressed viral load, if CD4 is 300 to 500, check every 6 to 12 months. I think every 12 months is more than sufficient there. And after the CD4 count is about 500, rechecks are optional. And there really is no clinical benefit to rechecking as long as the person is taking their ART and their viral load remains suppressed. And so I really try to emphasize to individuals that the key is adherence and viral load suppression, even though I'm often asked by patients what their CD4 count is. And so I really encourage people to keep asking, pay attention to their care, be involved, be engaged, but I really try to sort of redirect that focus to the viral load. Let's turn for a second then to the viral load monitoring and some definitions and managing first episode of virologic failure. These are fantastic slides that I thank David for. And so here's an example of somebody who starts antiretroviral therapy, HIV RNA or viral load monitored every 4 weeks until suppressed or below the limit of detection of the assay, and then with ART adherence continues to have virologic suppression. So this is an example of what we hope for and look for, and this would be virologic suppression. Here's a slightly different example where somebody has a viral load monitored every 4 weeks. The level is below limit of detection of the assay, and then on a routine check, one pops above the level of detection, and then perhaps the individual's called back, has a repeat, and it's right back to below the limit of detection and remains suppressed. We would call this a blip, a virologic blip, and there is data showing that this is unlikely to be clinically significant. So this viral load that pops above the limit of detection of assay, usually below 200, that comes right back to routinely suppressed in the setting of adherence, we would call a blip, and I really don't change my monitoring. I certainly don't change ART. That is not thought to be clinically significant. Let's compare that then here to a situation where ART is started, comes down appropriately to below the limit of detection, and then pops up above the limit of detection, and on repeat is above 200. So I think we all would call this virologic rebound or virologic failure. And I'll give you a couple of examples before ending the talk today, and then we'll talk about a couple of examples of this in the case discussion today as well. So management of first virologic failure, and I'm focusing on first virologic failure as opposed to the person who has failed a ton of different regimens and has really complicated resistance, though we will get to a case like that in the session today. So first, of course, I think, as you know, send a genotype resistance test, and I think the key point is making sure if somebody's failing an integrase inhibitor, adding an integrase genotype. I think that's easy to forget for us here, and for some of you that may be the case that it is a separate order. So you order the genotype, then you order integrase resistance. That's the way it is for us in our system. There are some tests out there that do both. There's a test called a GenoSure Prime, for example, that does both, and it really, there's not a right way, neither of the strategies is better, but just make sure if somebody's failing an integrase inhibitor, so the bictegravir, dolutegravir, elbaptegravir, relbaptegravir, that you're ordering an integrase genotype. Ideally send the genotype while failing the regimen or within 4 weeks of stopping, and that's to have the optimal sensitivity. If somebody has been intermittent with their meds or stopped their meds more than 4 weeks prior, I think sending the genotype can still be useful depending on what they were taking and how they were taking it. That ends up being more of a case-by-case decision based on what they were taking. Of course, in this setting of virologic failure, we assess barriers to adherence, reasons for missed doses, drug-drug interactions, over-the-counters that might interact in tolerability. One thing I was struggling with a couple of recent cases of virologic failure is while sending the genotype, continue the ART, stop it, or make an empiric change. And that's a question I'll put to colleagues here and to the community. What do you do, and does that 2 weeks you're waiting for the genotype matter? And I'll show you a couple of cases here in just a moment where that came up for me. And the guidelines are a little vague about this. I don't know, and I've struggled managing this in my own clinic, if it really matters, but I'd be curious what you all do. And then with resistance results, our strategy generally is to aim for a new regimen that has 3 active agents, and I think that always is optimal, though I do think there is reasonable data now that if you are able to use a regimen with high barrier resistance like dolutegravir, bictegravir, bocedurenavir, and you have 1 other active agent, that is probably enough. And if somebody has first virologic failure and let's say an M184V is their only mutation, and you're able to do bictegravir, dolutegravir plus 1 other active agent, I think we have good data now showing that that is sufficient. However, if somebody has a slew of new resistance and multi-class resistance and it's really complicated, then I really do my absolute best to come up with 3 active agents. But I think if it's first virologic failure, a simple NRTI mutation, a simple NRTI mutations, and you can come up with 1 of these high barrier meds plus another active agent, I think that tends to be sufficient, especially with a low viral load. But we'll have some examples of this to talk about in these slides and then in the cases today. So I'm going to go through 3 examples and then turn it over to you for questions, comments, and maybe ask colleagues what thoughts you want to add in terms of initial therapy or what you do when you're sending that genotype. Do you continue ART or stop? So here, these are based on a couple real examples from my clinic recently, just to make a couple of points and questions. So first, a woman in her 50s with HIV, multiple medical comorbidities, a lot of psychosocial barriers to adherence. She's been on and off a lot over the years. She had initially been prescribed a Tripla or a Favr's TDF-FTC when we were using that a lot. Because of her challenges with adherence, switched to bictegravir TAF FTC or Biktarvy. No past history of resistance, and HIV RNA or viral load levels on Bic TAF FTC not detected on multiple checks, and then on a routine check popped up to just over 8,000. I called her, we got her back in, we repeated it. It was about the same, sent a genotype including integrase. In this situation, because she was on a regimen where new resistance just does not happen very frequently, bictegravir is such a high barrier and it's so rare to develop new resistance mutations that I advised her simply to continue that regimen while we awaited the genotype. I did not make any change, did not advise her to stop it, did a lot to help address her adherence barriers, and she continued the Bic TAF FTC. There was no resistance detected on the genotype, and with better adherence to that, she has suppressed on that same regimen. So I present this as an example of what we mean of a regimen having a high barrier to resistance. So bictegravir, dolutegravir, boosted darunavir, individuals can fail those regimens, meaning they miss doses, their viral load comes up, but generally you send a genotype, there's no new resistance, and with adherence to that regimen, a person can suppress again. That is not the case with quote-unquote low barrier resistance meds, raltegravir, elvitegravir, the NNRTIs. So this was an example of somebody who failed a high barrier resistance med, did not change while we waited for the genotype, and suppressed again on the same, and with a lot of adherence support, she's currently doing well. To contrast that, this is a gentleman I've followed for a few years who's in his 40s, was prescribed rilpivirine TDF-FTC, that's Complera, had a period where he engaged, was doing really well, was coming to visits, and then really sort of just fell off his engagement, and he was really hard to reach, missed a number of appointments, took a lot of outreach and kind of a big team effort to finally get a hold of him. Turned out he had a stockpile of his Complera and was taking it here and there and sort of spacing it out. So I was very worried about resistance. When we finally got blood work, his viral load was about 10,000. On repeat, it was 13,000. Sent a genotype. In this situation, I'm not sure this is the right move or not, but actually advised him to stop Complera while awaiting the genotype because I had such a strong suspicion for resistance. Here was the result. Not surprising. You can see M184V, which happens with failure of FTC, K70, which happens with failure of TDF, and then the NNRTI mutations, which happen with failure of rilpivirine. So I think, and this was all new since baseline, so I think this was all as expected, and then he is now on this new regimen and also getting a lot of adherence support, and so far doing well. So an example here of somebody on a lower barrier resistance medication where with evidence of virologic failure had a strong suspicion of resistance, advised him to stop, and then with the resistance results in hand, crafted a new regimen which should have at least active boosted darunavir, active dolutegravir, and then the TAF is mostly active here, and FTC maintaining the M184V effect. Finally, a gentleman in his 50s, who I've known for years, who was on a regimen of abacavir, 3-TC lamivudine, and extended release nevirapine. Over the years, he had never really been eager to change that and had been doing well. He reported good adherence, but on a routine check, his viral load increased from routinely not detected to 17,000. We had a long discussion trying to assess why that happened. It's still not entirely clear to me what changed, but then 22,000 on a recheck. So again, very strong suspicion for resistance, sent a genotype, and in this instance, we were very strongly suspicious of resistance. His baseline viral loads were higher, and I was worried about him getting sick with stopping the regimen. So I actually changed him empirically to this regimen, which coincidentally is similar to the person previously. And really, this was because we suspected he probably had a 184V, a abacavir resistance, and NNRTI resistance, so crafted this empirically. And you can see here the resistance, which was sort of as expected, except for these thymidine analog mutations. And I had to dig back to records and notes all the way from 1998 that stated he was in a clinical trial of AZT. So my suspicion is he had some thymidine analogs underlying this that we didn't know about. Why he suppressed on this regimen for a long time and then developed virologic failure, I can't fully explain. But so I think This all made sense in retrospect, and this is an example of somebody, again, failing a relatively low barrier resistance regimen in whom we had a strong suspicion of resistance, so changed his regimen empirically while waiting the genotype, and now he's doing well on that new regimen.
Thank you for watching this edition of the Mountain West AETC Project Echo Didactic Series. If you like this talk, please click the red subscribe button and please check out other talks in our series. Until next time, this is Brian Wood, Medical Director, signing off.